as it rolls around every week or so, or maybe every month. Welcome back to Oncology, the Inquisitive Mind, OncoSnacks edition. As always, I am accompanied by my glorious and robust co-host, Dr. Michael Fernando. Take the robust comment as you want. How you doing?
Robust is a stretch. Still viral, still nasally, slightly
still
less
COVID.
robust. Still COVID, yes, but no, feeling good, Josh. And I'm not sure about how much we can claim that this is a fortnightly series anymore because we have been a bit hit and miss recently. Apologies for that.
We endeavoured to bring it back, but working full-time gives us limited time to fit it all into a week's schedule.
I think what you're saying, Josh, is that we need to stop working full-time.
Yes, and find another way to pay ourselves.
Yes, exactly. What are we talking about today, Josh? Before we go completely off the rails.
Oh, completely mad, some might say. We are continuing a trend from our last OncoSnacks, which was superficial thrombophlebitis. So check it out if you haven't listened to it already. But I thought today, Michael goes, why would we talk about this? But I wanted to talk about deep vein thrombosis and pulmonary embolism in the context of malignancy. I feel over the years it's one of those questions I'll get from interns, residents, ED specialists about what to put someone on when you'd consider A, B, or C. And I thought it's something that we can talk about because PEs and DVTs don't present classically like a textbook, and their management is somewhat nuanced. So it's worthwhile exploring.
Back in the old days, PEs and DVTs were colloquially known apparently as the great deceiver because before the advent of CTPAs and VQ scans, D-dimers, if you want to be really generous, they would strike people down without a hint of symptoms, or there was no real textbook presentation for PE, and they were a very common cause of sudden cardiac death. So very important to keep in the back of your mind, particularly when you're talking about cancer patients. And why is that, Josh?
Michael, before I answer that, have you ever heard of the phrase clot on the trot?
Is that like teaching on the run, but with thrombosis? Running thrombosis. Thrombosis with little Nikes that just sort of run around.
Maybe our 15-minute time slot is going to be taken up. But I have this vague recollection of my mother, who was a retired nurse, telling me a story of her patients that they would go to the toilet where they had a massive PE and end up drop dead on the toilet. And it was this thing in the 80s. I don't know if it's still maybe I've just skewed this from a 8-year-old child's mind, but I just remember this phrase, clot on the trot. Feel free to send us a message if you've ever heard of that, or if you think this is ridiculous, let us know also.
And that, ladies and gentlemen, is a rare insight into Josh's childhood that has turned him into the man he is today.
So proud of my, oh God, don't listen to this episode. Anyway, let's move on. Michael, do you want to talk about the background?
Well, yes. So as we know, and as I was trying to lead on Josh with a leading question before he decided to...
I switched it.
Before he decided to talk about clots and sudden cardiac death on the toilet, we know that patients with malignancy are at a high risk of developing VTEs, DVTs, PEs. So it is really a unspoken and in many cases spoken rule that if you think a patient has a PE, even if there's a bit of diagnostic ambiguity that we were alluding to before, you really need to do the investigations. Patients with cancer have a PE until proven otherwise. At the slightest hint, I've CTPA'd patients on no other basis that they have unexplained sinus tachycardia. More specifically, DVTs and PEs are the second leading cause of death in cancer patients after death from cancer itself. So all of your febrile neutropenias, your immune-mediated side effects, they all pale in incidence compared to the mortality cost of thromboembolism. Timely treatment is critical. We know this because if patients are at risk or they are about to have a massive PE, and remember these are patients who are not exactly crisp in the first place, you generally have a fairly short window before things start getting critical. So you need to act fast. But fortunately, Josh, acting fast is actually a fairly simple method these days. Josh, what are some of the risk factors for patients to develop DVTs or PEs?
Yeah, I think that's actually a pretty good question because, Michael, you said you scan everyone. Maybe that's an Austin thing. You come through the door, you get a CTPA before the diagnosis of your cancer. But they did find that up to 18% of patients who had a PE or had a DVT actually had a subsequent diagnosis of cancer. So that's how common clots are due to malignancy. So the first thing is having a malignancy, hospitalization, onset of chemotherapy, disease progression, if you've got central catheter lines, and the commonest cancers that you were expected to see a malignancy include lung at 17%, the pancreas at 10%, colorectal 8%, kidneys 8%, and the prostate at 7%. So if you've got someone with lung cancer, and how hard is that? You've got lung cancer where they probably have a diagnosis or might have a diagnosis of COPD, chronic obstructive pulmonary disease, and they're already short of breath. The idea of presenting with shortness of breath and pleuritic chest pain might be quite common for them. So being able to use these signs and symptoms is somewhat ambiguous, as Mike, you said, the slightest symptom you're going to scan someone, and I totally approve of that. But speaking of symptoms, you're going to say something, Michael.
Well done, Josh. Well read. I did want to come back to something that you just said, which is the patients who were known to have an active malignancy prior to the diagnosis of a venous thromboembolism. I don't know how it is with you, but in places that I've worked, in places that we've both worked actually, if a patient has an unprovoked PE, seemingly out of the blue, one of the first and most important things that you have to do in your workup is actually go hunting for an underlying malignancy, because cancer is such an important risk factor for a sudden, otherwise unexplained thromboembolus that sometimes DVTs and PEs actually lead to the diagnosis of cancer as opposed to the other way around. So if a patient has an unexplained DVT, they have no risk factors at all, always keep in mind that there might be more under the surface. In terms of symptoms, though, Josh, coming in a very roundabout way, see, two of us can play at the derailing game. These are fairly straightforward. These are some things that we all learn in med school, because recognition of people who might have a DVT or a PE is incredibly important, and it's really bread and butter stuff. So common clinical signs for DVTs, fairly stock standard stuff: swelling or edema, pain, warmth. They're usually unilateral, and that's one differentiator clinically between DVTs and something like chronic venous eczema from heart failure, as an example. Be aware that particularly if you've got an underlying malignancy, bilateral DVTs are a known clinical entity. They're rare, but they can happen. For PEs, sudden onset dyspnea, pleuritic chest pain, and cough are your textbook things. But remember, PEs are the great masquerader. Patients may not have any symptoms at all. As I said previously, I've had patients who are fairly innocuous. They've just had unexplained asymptomatic sinus tachycardia. You scan them and lo and behold, there's PE. So you've got to really have very sensitive antennae for patients with potential VTEs in a malignant setting. In terms of physical examination, much more useful for DVTs rather than PEs. In the DVT space, look for things like dilated superficial veins, unilateral edema or swelling, warmth, tenderness, erythema, larger calves unilaterally. I think for our physician's exam, Josh, it was part of the exam that we actually had to get out a tape measure and measure one calf and then measure the other and compare whether there was a significant difference between the two. But you can probably just eyeball that in most cases, because it is usually quite distinct, and patients will be able to tell you my right calf or my left calf is not normally that big. If it's PEs, examination findings are often non-diagnostic, and this is where the importance of scans come in. But if you really want to be old school, you look for things like hemoptysis. Now, hemoptysis is a fairly late sign because it indicates underlying ischemia of the lung. So it's actually very uncommon these days, particularly with the awareness of PEs, the earlier diagnosis. It's actually uncommon for patients to present with hemoptysis. Massive PEs present with syncope and signs of hemodynamic compromise, such as hypotension and shock. And in the acute setting, hypotension is the only reason to thrombolyze someone, though in a patient with malignancy, that discussion becomes a lot more dicey because you're also putting them at risk of bleeding, particularly if they have brain mets as part of their disease. Other common signs on examination are tachypnea, tachycardia, chest pain, diaphoresis, or an S3 or S4 gallop, which is audible in 30% of patients. I'll be honest, I've never heard one of those, but hey, if you've heard one, then you know what it sounds like, I guess. In terms of investigations, for non-malignant patients, there's always the question of whether you do a D-dimer or whether you don't. As we said in our superficial thrombophlebitis episode, do not bother with malignant patients because you are always going to get an elevated result. And even if you don't get an elevated D-dimer, you're still going to do a CTPA anyway. CTPAs are the standard of care for PEs. They're much, much better than VQs. So unless the patient has, for example, an iodine contrast allergy, you should really go for a CTPA every time. You should have a look at doing an ultrasound for lower limb DVTs, or even after you've diagnosed someone with a PE, because the burden of overall clot can determine whether you recommend the patient stays on bed rest. It can also sort of, depending on where you work, determine whether you want to keep them on Clexane, or otherwise known as low molecular weight heparin or enoxaparin, for a period of time. In terms of other sort of simpler stuff, so ABGs, not really helpful, but they can reveal things like hypoxia, hypocapnia, respiratory alkalosis. Troponins might be high in the setting of a very large PE because you've got cardiac strain. ECGs, Josh, do you know what the most common finding on an ECG with a patient with PE is?
Sinus tachycardia. That is a trick question, my friend.
That is a trick. Well, the trick question is that the most common finding is a normal ECG, but if you're going to be specific and say what is the most common abnormal finding, sinus tachycardia is absolutely correct.
Meanie.
It was a double trick question. And so this whole idea of S1Q3T3, yes, it's described, but like so many clinical signs, it was done before the era of investigations, and it is neither sensitive nor specific for PE. There are a couple of other things, but I feel like that we've gone over the investigation component for far too long. Josh, do you want to talk about some treatment? Because it might sound easy, just whack them on some blood thinners and call it a day, but there are a few subtleties.
Michael, there are some caveats in regards to which anticoagulation you choose. And as new drugs have come on the scene, the options have increased. There are multiple agents. So the first is subcutaneous, low molecular weight agents. The common ones you might think of is enoxaparin, also known as Clexane, dalteparin, and tinzaparin. I personally have never used tinzaparin, but I'm assuming it's out there. There's others which include, it's always out there, include oral factor 10A inhibitors such as apixaban, rivaroxaban, and edoxaban, and oral thrombin inhibitors like dabigatran. And then you've got the old school IV or subcutaneous ultrafractionated heparin, so unfractionated heparin, and then you've got warfarin. And the question is, what do you do? How do you choose? And I think I'm going to try and break this down by class and then the caveats within that class. So if you've got the factor 10A inhibitors, Michael, as a sidebar, these are the best ones.
Spoilers,
everybody.
Alert.
Spoiler alert.
You can just stop listening now, basically.
That's it. You have apixaban, and that's the preferred monotherapy. It doesn't need heparin bridging. It's wonderful. There's a randomized controlled trial compared to low molecular weight heparin, and it was just as efficacious. The benefits is that it might carry lower risks of bleeding, particularly the GI tract. And remember, if you've got a GI malignancy, you want to try and minimize that potential complication as much as possible. And that's compared to rivaroxaban or edoxaban, which are the two siblings of apixaban, you might say. The thing is, it's a twice daily preparation. And if your patient hates taking tablets, which I'm assuming they're going to be in a lot because this is oncology for the tableted mind, then there's other options like rivaroxaban, which is a once daily preparation. The thing is, rivaroxaban, you want to avoid it in upper gastrointestinal cancers because there is more bleeding, and that's been reported with this agent. And the other thing, you want to take it with food because it maximizes absorption. Moving on to another class, so enoxaparin or low molecular weight heparin, it works. It's an injection. It's either once a day or twice a day, depending how you kind of formulate it. But it's an injection in the stomach. And if you've got cancer and it's a long-term injection, that's going to suck for the patient. Moving to the third class, dabigatran. So dabigatran is, it's an oral thrombin inhibitor. Came out around the same time as apixaban and rivaroxaban, give or take 5 years, but it hasn't taken off in the same way. I think it hasn't really been compared to chronic low molecular weight heparin. So it's a bit hard to recommend in active cancer. When you look at the first line, and if you break it down, the simple things, and I'll get rid of all the systematic reviews and the meta-analysis I've got in our notes, Michael. First line, use apixaban. right? It's a factor 10A. It works well. There's evidence to support it. There's meta-analyses to support it. Then the next question is, what about a DOAC versus Warfarin? Warfarin is old school. It works, but it's a pain to control. And a lot of our patients are older, and that means a tablet once a day, multiple blood tests, issues if they have grapefruit.
There's also some older evidence, Josh, with Warfarin that patients with cancer, due to interactions with various chemotherapy agents or even interactions with the cancer itself, it's actually more difficult to keep a patient within the therapeutic INR range. So they spend more time either subtherapeutic or supratherapeutic and have higher rates of clots and bleeds compared to, at the time, it was just compared to things like heparin, but it's probably comparable to factor 10A inhibitors as well.
Considering how difficult warfarin is to manage when patients
they
don't have cancers, that's not a surprising factoid. But I love your factoids, Michael. Thank you for sharing.
This is Oncology for the Inquisitive, Michael's factoids as well. We're just throwing out alternative titles. We'll have a poll on what we should actually be called coming soon.
That's it. And don't forget to like and subscribe if you like our podcast. Mikey, I might move to second line, and then if you want to chat about contraindications and special populations. So second line is unfractionated heparin, followed by warfarin. So if you can't have any of those classes, then move on to that. Don't kind of go looking for something else. And the reasons why is kidney problems, if you're unstable, if you're obese, like there's not a lot of evidence for Clexane. If you're over 150 kilos, you're still going to have to do factor 10A levels to figure out what's going on. If they've discontinued or you've reversed anticoagulation, unfractionated heparin, if you've got an extensive clot burden, people will be more likely to look at sort of unfractionated heparin, but Mike will go into that a little bit more. And then if you really want tight regulation, but again, I don't know if that's truly going to be the reality with warfarin.
No, I think that the difficulty and the impracticality of getting tight control with warfarin and the ubiquity and convenience, really, of anti-10A inhibitors have meant that warfarin has really fallen out of this space. But there are exceptions. So some patients will have contraindications to anticoagulation as a whole. If you've got patients where you're consistently worried about bleeding, that's the main thing. Whether that's GI bleeding, if you have a patient with melanoma or renal cell cancer, you would be petrified about them having brain mets that can spring leaks because they're very vascular tumours. Patients who are actively bleeding and need an anticoagulatory strategy, as it were, which we have seen. I've seen it a couple of times. The alternative is a inferior vena cava filter, which is exactly what it says. Josh has just made a face. I can tell that he doesn't like these very much. But basically, it is exactly what it says on the tin, which is just a filter that sits in the inferior vena cava. It doesn't do anything for the prevention of DVTs. That's the first thing that we should say. With the inferior vena cava, all you're trying to do is stop those DVTs becoming PEs. And I had a colleague ask about an IVC filter for a patient who had a DVT but then also had a known PE. And I said, well, what is even the point of putting an IVC filter in because they've already got PEs? You might stop the load becoming bigger, but we need to anticoagulate them. So IVC filters should not routinely be placed for the initial management of VTEs in any population because they are really a compromise. And that I think we've made that clear with Josh's silent facial expression and my initial foray into this subject. There are no randomized trials that have studied the safety and efficacy of IVC filters in the treatment and prevention of VTEs of patients with cancer. Retrospective analysis of patients with cancer-associated DVTs, there was a very high rate of recurrence, 32 versus 17% of patients. For patients who had an IVC filter compared to those who didn't, had a recurrence of VTE. The other practical thing, of course, is that IVC filters, in addition to be putting in, need to be taken out. If you leave an IVC filter in, it's going to clog and you're going to have absolutely no venous return from your lower limbs because the IVC filter is just clot. So they are a temporizing measure. Usually you put them in, you get the patient over their bleeding diathesis if possible, and then you take them out, put them on some anticoagulation. So they're a temporizing measure only to be used if the patient has an absolute contraindication to any therapeutic anticoagulation. And then you have the special populations. For patients with renal failure, this is one of the few areas that apixaban is very much contraindicated. You can reduce the dose to 2.5 milligrams twice a day to a certain threshold, but there does come a point where there is not enough evidence to safely prescribe apixaban for patients with severe renal failure. And those patients are those that have a creatinine clearance of less than 30 mils per minute. What we do with these patients, it does vary from place to place. I frequently use dose-reduced enoxaparin with a once daily injection as opposed to a twice daily injection, 1 milligram per kilogram daily. But other places will use IV unfractionated heparin followed by warfarin. For patients who are hemodynamically unstable, you need something that is going to be reversible. So heparin is your go-to, and you can usually give it as an infusion because you can make micro adjustments. If patients have an anticipated discontinuation or reversal of anticoagulation, so you've got a patient who is going for surgery. That's going to be the main example there. You want, again, something that is going to be easy to reverse. Patients with extensive clot burden, I mentioned this before, it is probably better to use unfractionated heparin or enoxaparin, low molecular weight heparin, that is, for patients with a high or an extensive clot burden. Basically, the idea is that this is more effective at quickly stabilizing the clot. And also, if a patient needs a procedure such as a clot retrieval, you can reverse it, reduce the risk of bleeding. They can be monitored invasively if required. It gives you a lot more flexibility. Those are some of the special populations that you might need to move away from the standard apixaban and forget strategy that we're using these days. It's also important to note that every hospital or every tertiary centre will have a haematology unit. There are a lot of haematologists that specialise in thrombotic medicine and management of thromboses. I always consult my friendly neighbourhood haematologist if there are any of these special populations for advice. It's just safer that way. In terms of the duration of anticoagulation therapy, in the first episode, usually of a peripheral venous thromboembolus, anticoagulation needs to continue for at least 3 to 6 months, provided there is a low bleeding risk and no contraindications. However, in most patients with an active cancer and a DVT or a PE, anticoagulation has to be indefinite. The reason being, the causative agent is the cancer, and the cancer isn't going away anytime soon. So you need to keep on thinning out the blood to counteract the cancer, making it sticky. The recommendations on the UpToDate article that we used as the main source for this episode recommend yearly reevaluation of the benefit-risk ratio for anticoagulation to avoid unnecessary morbidity from bleeding or recurrence. That is especially important in patients with cancer. Cancer is a dynamic, ever-changing condition. Patients' disease burden changes, their performance status changes, their sites of disease change, and so the risk-benefit is going to be a constantly changing proposition. So it's important to always ask yourself the question, does the patient still need to be on anticoagulation? And I guess the other thing to keep in mind, of course, is their prognosis as well, because there's no point anticoagulating someone and putting them at risk of bleed if that is indeed a clinical risk in that scenario when their prognosis is very poor as well. That's a very grim note on which to end, Josh. DVTs and PEs, they're pretty easy to manage in patients with cancer, at least until they're not.
That should have been the byline.
Yes, the subtitle. Easy to manage until it's not.
Exactly. Well, we hope you enjoyed our episode, and we will catch you all for more oncology goodness in our next one.
Sounds good. We'll see you then. Bye.
See you. Bye.